Welcome to the Johns Hopkins Medicine online webinar series. Today, our neurosurgeons, Dr. Chetan Bettegowda and Dr. Judy Huang, will be speaking about trigeminal neuralgia surgery, what you need to know. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to a live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation. Also, your email address will not be shared by any third parties. We will do our best to answer all questions we receive during this Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome our presenters to begin their presentation.
Thank you so much, Amy. I want to thank all our participants today for joining us in this evening. My name is Chetan Bettegowda. I'm a neurosurgeon at Johns Hopkins. One of my major subspecialties within the field of neurosurgery is to help take care of individuals who have facial pain, specifically trigeminal neuralgia. And I'll allow my co-host, Dr. Judy Huang, to introduce herself as well.
Good evening. Thanks to all for participating. My name is Judy Huang, and I've been at Hopkins for about 18 years, and we are very happy that you're joining us tonight to learn more about trigeminal neuralgia and the possible surgical treatments. I also have a focus of clinical interest in blood vessel problems, and luckily trigeminal neuralgia is also one of those problems that has nerves involved and blood vessels. So hopefully that our information session will be of help to you.
Thank you so much, Dr. Huang. And just by way of introduction, really would want this session to be as interactive as possible. We know that the web-based format can seem a little bit impersonal or distant, but we're trying to encourage participation from all of you. So we would very much welcome any questions or ideas or thoughts that you might have that you think are relevant for our discussion today. Please do feel free to share those, and we'll try our best to answer questions as the hour progresses. But just to take a couple of moments to discuss what is trigeminal neuralgia for those in the audience who may not be familiar with it. Trigeminal neuralgia is a clinical diagnosis, meaning there is no MRI scan or CT scan or X-ray or blood test that tells if an individual has it or doesn't. Really is classically defined as sharp, shooting electrical pain that affects one half of the face. Other characteristics of the pain could be things like stabbing, lancinating, but sharp. Those are the true words that many individuals with trigeminal neuralgia will describe the pain. It's often triggered by a classic set of things, such as brushing the teeth, talking, chewing, wind, shaving, cold. These episodes tend to be brief in the earlier parts of trigeminal neuralgia, but as the process progresses, unfortunately for some individuals, the duration can last minutes or even longer and then subside. So it's an episodic facial pain that affects one half of the face that has very characteristic triggers and quality of the pain. And so why do we sort of make a point to understand these factors when we evaluate individuals with facial pain? The reason is that the potential for benefit for the surgical outcomes that Dr. Huang and I offer are directly related to our ability to understand whether someone has trigeminal neuralgia or not. So the success rates are very, very high for the three primary treatments that we offer, greater than 70 or 80% when someone has trigeminal neuralgia. Unfortunately, these same treatment modalities, when used on someone who does not have TN, the success rates are far, far poorer, and unfortunately may introduce a new problem such as numbness of the face or sensory changes. And so there are three major treatments that we offer here at Hopkins. The first is called a microvascular decompression. And what is that? In many individuals who have trigeminal neuralgia, there's a blood vessel pushing up on the nerve. As blood flows through that blood vessel, as the heart pumps, that nerve can get hit and irritated. And the thought is that this irritation can lead to injury of the nerve that can then result in people developing facial pain. So the goal of this surgery is a very simple one. It is to merely separate the blood vessel from the nerve using little cushions that we make that are made of Teflon. In order to do this, patients are put to sleep. Incision is made behind the ear. A small opening in the skull is made, and Teflon pledgets are under microscopic guidance in sort of a minimally invasive fashion used to separate the blood vessel from the nerve. This surgery is extraordinarily successful, helps approximately 80% of people, and is our best chance of providing long-term and potentially even lifelong pain relief. Up to 80% of those individuals who derive benefit from this procedure can be free of medications for a very, very long time, 10, 20, or more years. The second option is called a glycerin rhizotomy. This is an outpatient procedure where people are put to sleep. A small needle is inserted in the cheek, threaded up to the base of the skull where the trigeminal nerve exits the skull base. Using x-rays and electrical stimulation, we identify precisely where that nerve is and inject a material called glycerin that coats the nerve. Similar to the microvascular decompression, this too has very, very high success rates, around 80%. The difference here is that because it's a slightly different approach, which is a chemical that we're using to prevent transmission of the pain sensation to the brain, it's a more temporary type of procedure in terms of pain relief. The average duration of benefit tends to be 1 to 3 years, but this procedure can be repeated. And because it is an outpatient procedure, there are many more individuals who might be safe candidates for this procedure. The third procedure is called stereotactic radiosurgery. Gamma knife, cyberknife are two examples of methodologies that can be used to take care of trigeminal neuralgia pain. Dr. Huang and I work with our experts in the radiation oncology department to develop precise treatment plans for this form of treatment for trigeminal neuralgia. What does this entail? Individuals who wish to proceed with stereotactic radiosurgery will get an MRI scan and a CT scan that are of extraordinarily high resolution, precise pictures that allow us to see the trigeminal nerve in great detail. With this, we're able to work in tandem with the radiation oncology team members, including physicists and radiation oncologists, to be able to identify the trigeminal nerve and deliver in one treatment that lasts approximately 45 minutes, high dose of energy to the nerve. This session is painless, the individual is wide awake and stays still while the stereotactic radiation machine actually moves around the head in order to focus the energy on the nerve. This treatment is also very, very effective with success rates of around 70% or so. So all three of these options are available to individuals who are treated here at Johns Hopkins. I'll pause here and allow Dr. Judy Huang to discuss further about our Trigeminal Neuralgia Center.
Thank you, Dr. Bettegowda. I am very glad that this description is being recorded because I think your explanation is so informative. I'm sure that there will be people who will want to listen to that again. I mean, it really includes all the details that everybody needs to know about trigeminal neuralgia. So, we are here at Johns Hopkins ready and able to help people with trigeminal neuralgia pain. We understand and we don't take any offense if people, are not interested in surgery. Many times people who suffer from trigeminal neuralgia have actually been on medications for quite some time. And that is something we completely agree with and we encourage. We are here to help with pain only if the medications have stopped working or are providing so many side effects that it becomes very difficult to cope with the trigeminal neuralgia pain. And that's where we feel we can step in and help with the pain. We understand that everyone has experienced their trigeminal neuralgia pain for different lengths of time, in different parts of the face. have responded differently to medications and have had differing changes to their life styles because of their pain. So we also know that there are people who have tried some treatments for trigeminal neuralgia, and whether that's stereotactic radiosurgery or an MVD in the past, we understand that people come with different previous treatments, and we are here as a surgical center to help everyone, whether it's a first-time diagnosis and never before treated with any surgical procedure, or people who have had other surgical procedures. And so that's, I think, one of the reasons to seek out care at Johns Hopkins, is because we really offer the comprehensive package and really take into account what your history has been in the past. We also take into account your other medical conditions and your medical history and in fine detail, so that we understand that there are certain people who are better suited for certain surgical procedures. And we do make a concerted effort to take that into account as we design the individualized treatment strategy for each person. And it doesn't matter if you're coming from across town or across state borders, we will do that for you. And I think that hopefully people understand that coming to Johns Hopkins is really for a very comprehensive evaluation that is tailored to you and your specific condition. I wanted to point out that in these times of the pandemic, things are very different nowadays. And to reassure you that here at Johns Hopkins, we have taken extraordinary measures to continue to care for people who need our help, especially people in severe pain, acute pain, and to provide it in a timely fashion. And this is not impacted at all by what's going on around us in the world with the pandemic. We have implemented all the recommended safety measures, and we are very particular with our procedures. And so there will be someone to guide you through that, which includes testing before surgery and really assurances of safety throughout your care. In addition, for people who are new patients to us and who have not seen us before, we offer a full accessibility with video telemedicine visits. And we welcome people to contact us and see us through a video and audio platform, such as what we're doing today, because we understand that travel across state lines or across town is actually rather difficult right now. And most people would prefer not to leave their homes very much. And we fully understand that. And we are really here to make that process of evaluation as easy and convenient for you as possible and as safe as possible. And so hopefully the comfort of your own home is where you'll be as you meet us and we talk about your situation. So we are very much encouraging video telemedicine whenever it's possible. And we are ready and able to help you with your trigeminal neuralgia. That's it for me for the first comments. I would love to understand a little bit about our audience. So maybe we could start with the first poll question that Amy will throw up.
So this first question on the screen here is a simple one. Have you been diagnosed with trigeminal neuralgia? We'll give folks a moment or two to submit their responses, but just to extend Dr. Huang's comments is that we do indeed take care of a number of individuals who come from quite a distance to receive their care for trigeminal neuralgia at Hopkins. And we have the good fortune of taking care of several hundred patients every year over many, many years. And so we certainly have a considerable amount of expertise, and that's certainly within the neurosurgical service with Dr. Huang and myself. But in addition, we have great collaborations, as we discussed previously, with individuals within the radiation oncology department for stereotactic radiosurgery, as well as with neuroradiology, where it is important to be able to understand the anatomy of the trigeminal nerve and understand if there is a vascular compression to help triage which individuals may be best suited for which treatment. And so we really do try our best to integrate all the expertise possible within the Johns Hopkins Hospital to deliver the very best comprehensive care, as Dr. Huang mentioned. And as a part of this, we've had the good fortune of being recognized as the #1 neurology and neurosurgery department in the United States by the US News and World Report for several years now. So we really feel very fortunate to be able to work with all of you.
And I will just also mention there will be an opportunity at the end for us to have to show our contact information, and for an opportunity for you to indicate if you wish to be contacted by any one of us. So it looks like we have results. So 63% of the participants have been diagnosed with trigeminal neuralgia, and 38, which doesn't quite add up to 100. So maybe that'll be 37. So a little more than 100%. So great. Thank you for participating in that poll. I think I saw a first question already. So how about we launch into the questions? I'll read the first one is, how do you determine when it's time to have surgery to treat trigeminal neuralgia? That's a great question. I usually say that it is a very personal decision, because most likely people have tried all the medications that they can try. And a lot of times medication does work for a while and takes care of the pain, and it's in remission. And it can be actually very excellent and complete pain relief for many years. I think it's time to think about surgery if the pain medications no longer are effective at blocking pain and the symptoms start coming back, and that despite an increase in the dosage of medication, the pain is back with full vengeance. I think that if the situation is such that the medications are causing such side effects that it also becomes difficult to work or difficult to eat, difficult to engage with your family and do all the things that you want to do, then that represents a failure or a maximum effectiveness of medication, because medications do tend to have side effects at some point. So if one reaches that point, I believe that then it's a very appropriate time to start thinking about surgical interventions. Dr. Bettegowda, do you have anything?
Yes, I think these are
ideas?
Yes, I think that was a great summary, Dr. Huang. I think I would add a couple of points. One is that we always encourage folks to try to stay ahead of the pain. And what do we mean by that?
Mm-hmm.
We know how debilitating TN pain is. It's life-altering. It really just brings people's quality of life to a very, very low level, almost instantaneously. And so what we would like and encourage individuals to do is to try to get in touch with their local providers if they're on medications, the neurologist that they work with, the primary care doctor that they're working with, or the pain management specialist, and try to do this in a bit of a proactive manner, because our experience has been that if the pain gets to be intolerable, it becomes very, very difficult to have that pain subside with medication management. And we understand that sometimes it's hard to predict, but that in regards to when to treat or consider surgery really is as we start to see an increase in the pain with respect to, regardless of medications being in place. But we'd like that to be sort of in a period before people
Mm.
get into extremis, meaning
Mhm.
we unfortunately see folks who are in so much pain that they're not eating, that they're not drinking, that they're losing many, many pounds very, very rapidly. And that's a very, very challenging pain situation to have people come out of from a quality of life and pain control standpoint. And of course, we're very, very happy to schedule folks who are in such unfortunate scenarios for urgent or emergent evaluations. But even in those scenarios, it can take a little bit of time. And that period of time, people can sort of struggle. So we do ask people to be a little bit mindful of the pattern of pain that they're having, seeing this crescendo of pain build up with more frequent attacks or more severe attacks, and to start to reach out to the appropriate physicians, whether it's us here at Hopkins or perhaps a local provider who's managing medications, to stay a little bit ahead of the pain.
The second question is, what are the risks of having surgery to treat my trigeminal neuralgia? Will it return? Dr. Bettegowda, do you want to start with that one?
So I'm sorry, I was looking, I think, at a couple other questions. Would you mind repeating that, Dr. Huang?
So should I, okay, so what are the risks of having surgery to treat my trigeminal neuralgia, and will it return?
Yeah, great question. And so the risks really, I think, vary based on which treatment modality we move forward with. So let's start with the first one we discussed, and that's the microvascular decompression. That's the surgery where we open up the skull in an attempt to separate the blood vessel from the nerve with little cushions. So again, this is a very safe and effective procedure. So when we think about risk, this is fortunately something that is very unlikely to happen. But the types of risks associated with that surgery occur because it is an open neurosurgical procedure. We open the skull, we open the covering of the brain. And so there is a small risk for things like cerebrospinal fluid leak, which is the water that bathes the brain that can leak out of the incision. Small chance for hearing loss because the hearing nerve sits right next to the trigeminal nerve. And anytime we operate on the nerve or manipulate the trigeminal nerve, the most common side effect that people can see, and that's across all three of the treatments that we offer, is facial numbness. And the reason for this is that nerve controls all the sensation to the face. It controls pain, of course, but also warmth, cold, vibration, pressure. And so you can imagine that removing that nerve's ability to feel pain, whether it's with the microvascular decompression, which has the lowest rates of facial numbness, or one of the other options like stereotactic radiation or rhizotomy, which have about a 50% rate of some amount of facial numbness, that is the number one side effect that many people experience. Now, when we talk about numbness, it's not that the face droops. Many individuals ask us, is my face not going to work? Is it going to look asymmetric? Am I going to look like I've had a stroke? No, this is purely a sensory phenomenon, meaning individuals touch it, it feels different than the other side. In my experience, the vast majority of our patients are happy to trade a little bit of numbness for their facial pain. That numbness can improve, but in some cases can persist or be permanent. The second procedure that we discussed is a rhizotomy. In addition to the numbness, because we insert a small needle in the cheek, there can be some bruising or swelling in the cheek or jaw area. That's temporary. It's an outpatient procedure, typically 30 minutes or less. People go home later that day. So it's usually a very quick recovery period for that procedure. And the third procedure, which is a stereotactic radiosurgery, the cyber knife or gamma knife, there is no incision, there is no anesthesia, there is no cutting. So really the recovery time is instantaneous. So people come in, have their treatment and leave. Maybe people can develop a little bit of fatigue, and in a delayed fashion is when the facial numbness may begin to appear. So those, I think, are the main considerations for the three treatments that we primarily offer.
Great. I'll take the next question, which is who diagnoses trigeminal neuralgia? So I think that's a great question. I have found that trigeminal neuralgia is usually diagnosed by one's primary care doctor or neurologist. So usually when someone begins to experience the facial pain, in a specific pattern, they see someone quickly and accessible, who is accessible, and that's usually a neurologist close to them, who is able to immediately start medication to help control the pain and also to make the diagnosis. Of course, we are able to diagnose as well because there are some people who have facial pain and it's not characteristic of trigeminal neuralgia, or it has some mixed features. And so we are also happy to evaluate people to see whether or not they have trigeminal neuralgia. But the most usual circumstance is that neurologists can diagnose trigeminal neuralgia.
I think there's a follow-up question to that, Dr. Huang, that's asking, are there any clinical trials going on that involve new treatments for trigeminal neuralgia? And indeed there are. And we were fortunate to have one of those clinical trials at Johns Hopkins. I believe we were the first site. And Dr. Huang and I are both investigators and lead investigators for this trial. It is testing a medication to see if we can actually mitigate the facial pain. And this has been FDA approved for the treatment of migraines, which, as we all know or have heard about, is a different type of headache or pain syndrome that can also involve the face. And it's called, I always mispronounce this, rimegepant. And it's a study where individuals were either treated with the drug, rimegepant, initially, and then crossed over to a placebo, or vice versa, initially treated with the placebo and eventually crossed over to rimegepant. And this trial is ongoing. Individuals are not told about which arm they're in, nor do the physicians know. So it truly is a blinded study. And this is for individuals who have tried additional options already and have failed medications, surgical options, and still have persistent pain. And that is an ongoing trial. Be very willing to discuss this further if that would be of interest. So thank you for that wonderful question.
Great. Great. And the next question is also an excellent question. How is TN from multiple sclerosis different from TN from pressure on the nerve in terms of selecting which one of the three surgical options? So I think that that is a very astute observation that MS is a nervous system disorder that is a little different in terms of treatment options for people who have trigeminal neuralgia. In our experience, the preferred treatment for TN in the presence of MS is the rhizotomy. And that is because that is the most effective and can be repeated safely. The response of the MVD procedure in patients who have MS is more modest than the success when one does not have MS. And so it is a procedure that we would like to spare people from going through if they have MS and it's not going to provide a long-lasting relief. And then on the flip side, also, the stereotactic radiation or CyberKnife is also not as highly preferred in people with MS because there's radiation involved near the brainstem, and we'd like to minimize that kind of exposure. So in answer to that question, it's really the glycerin rhizotomy is the preferred option. And,
okay. And I think to follow up on that, Dr. Huang, is that sort of one of the things that I hadn't mentioned about these three options is that they really, for many individuals, could be eligible for all three. And we have a detailed discussion to try to develop a personalized plan, but that the sequence in which they're done can be personal, but does not close the door for other options. Meaning, let's say an individual has a microvascular decompression and the pain recurs, unfortunately, many years down the line. That individual is still eligible to have a glycerin rhizotomy or have consideration for stereotactic radiosurgery. And vice versa, an individual might say, gosh, I'd like to have an intervention that's less invasive, does not have a long recovery time, is outpatient. So let's start with the glycerin rhizotomy and see the period of time I get benefit from. and then if heaven forbid the pain were to return at some point, would still be eligible for either repeat rhizotomy, stereotactic radiosurgery treatment, or the microvascular decompression if the situation warrants it. And so it really is a detailed discussion. The procedures that we can repeat more than once really are, as Dr. Huang mentioned, the glycerin rhizotomy. When we do that procedure a second or a third or fourth time, we often do it with both glycerin and radiofrequency. What is that? Radiofrequency is not radiation, although the name is very confusing. It really is a thermal injury to the nerve. So it's the exact same procedure as the glycerin rhizotomy, where people get put to sleep, sort of small needle, identify the nerve, inject the glycerin, and through the same needle, heat up the nerve. So give the nerve both a chemical injury and a thermal injury, a double whammy to try to keep the pain under control. We do this for individuals who have recurrent facial pain, and we don't do it as a first option because there's slightly higher rates of facial numbness. And we try our best to avoid that if at all possible. But that is the most frequent procedure that we do repeat if the pain were to recur. The stereotactic radiosurgery is involving radiation and high doses of it. Therefore, in general, it's safe to give individuals over a lifetime 1 or 2 stereotactic radiosurgery treatments for trigeminal neuralgia. The microvascular decompression really is a procedure that we prefer to do once and only once. The reason for that is that scar tissue can build up. The goal of surgery is an anatomic one, meaning to separate the blood vessel from the nerve. We often get asked questions, do those pledgets move? Is it possible that the nerve can get recompressed over time? And the simple answer to that would be very, very unusual. We never say never, but that'd be an unusual scenario where that would happen. And so that's a procedure that is very uncommon to repeat or have done more than once in a lifetime. And so just to give a little bit more framework as to how to triage these 3 options and what would happen if the pain were to recur after one of those procedures.
Yeah, I agree completely. So I think we will launch another poll, and then I'll take the next question. So this question is, have you seen a neurosurgeon for your trigeminal neuralgia before? And so as you're answering that question, I will read the next question that I will attempt to answer, which is, if I had an MRI and the results are unremarkable, will surgery help relieve the pain? Are there other options? So that's a great question. So believe it or not all MRIs are the same. So there are specialized MRIs that we can do here at Johns Hopkins, and there are other facilities that do as well. So we pay particular attention to make sure that you've had an MRI that really focuses on the trigeminal nerve. It's kind of like having a zoomed in view of that area of the brain. You know, it's not helpful to see the top part of your brain at all. We really want a zoomed in picture of the trigeminal nerve. And oftentimes that special MRI will reveal something that a normal MRI does not reveal. So the first step is to make sure that the kind of MRI that you've had is one that is dedicated to looking at the trigeminal nerve. So that's the first step. So in the event that that specialized MRI is unremarkable, you know, we still find it useful to look ourselves at that picture and to have our radiologist look at that picture, because those pictures sometimes are, you know, it's good to have multiple people look at the same picture. And so I would recommend that as well. Now, if there is really no suggestion of a blood vessel nearby, yes, we could talk about the use of the other options. And that's where, as Dr. Bettegowda mentioned, we really take into account other treatments that you've had, or response to medications and so forth to choose which one would be best for you. And so that is a very personalized and individualized discussion of the other options. And now back to the poll. So we see that 44% of all the participants have seen a neurosurgeon before, and we have a spread between the people who have not seen one and maybe are interested in seeing one. So that's great. And then the next question, which for Dr. Bettegowda, do you know if acupuncture is effective?
Great question. So I would suggest that this is a great option for individuals to explore if they feel like this non-classical approach is something they would be interested in. And anecdotally, or in my experience, I think about 20 or 25% of patients that I've met and helped take care of have found benefit from acupuncture. The beauty of acupuncture is that it really has minimal to no risks. It's non-invasive, can be done without the prescription of a medical professional. And typically, if there is any unwanted effects from it, it's transient and quickly wears off. And so certainly for someone who might be interested in it prior to considering a surgical option, or perhaps after having a surgical procedure performed and the pain recurs, I certainly do encourage folks who are interested in acupuncture to try that. The other sort of related options that I've seen patients benefit that don't involve surgery or medications are things like wellness clinics, meditation, going through programs to sort of lifestyle modify. And again, these are not something that would be appealing to some fraction of the patients we take care of. And certainly we know that it's not a cure for everyone, but I have seen, and we have seen, that it can help individuals in the right setting, in the right circumstances. So it is certainly something worth considering if it's of interest to you.
The next question is relief from trigeminal neuralgia instantaneous after surgery? So for the rhizotomy, it is actually pretty noticeable, pretty dramatic. I would say that procedure is associated with the most immediate relief. And that is why when people are in extreme circumstances, like Dr. Bettegowda mentioned, of not being able to eat, not being able to drink, and being in such severe pain that they can barely get out of bed, the rhizotomy is actually a very good option because it is instantaneous. The MVD, or the microvascular decompression, that also results in pretty significant relief quickly. Of course, there is the associated surgical recovery, but it is pretty, so the pain becomes the incisional discomfort, which takes a few days to recover from, but the facial pain is resolved pretty soon after surgery. The stereotactic radiation option, that is associated with the longest interval of time that is necessary before one feels relief from the facial pain, and that can take weeks. So there is a difference in the speed at which the pain relief occurs.
I think those are very excellent points, Dr. Huang, and certainly considerations we take into account as we counsel individuals as to which option might be the most appropriate at that time. I think another outstanding question was just populated, and that is, have you experienced chronic Lyme patients having TN? Are there studies being done? And sort of what options might exist in that realm? So trigeminal neuralgia, in the classical sense, is not triggered by a virus or an infection like Lyme's. So we know things like shingles, the herpes virus, in some people can affect the trigeminal nerve and result in a facial pain that's often burning or searing and can be quite disabling. Similarly, I have had patients who have developed Lyme's and also have facial pain. Now, the link between Lyme's and facial pain is not as strong as we've seen with some of the other things, such as shingles. And so I think it's still an area that's being fully developed and further explored. But certainly we know that anything that it can impact the trigeminal nerve, whether it's an infection like Lyme or shingles, whether it's a tumor like a meningioma pushing on the trigeminal nerve, or it's multiple sclerosis where the body is attacking the covering of the nerve. All these things can indeed impact the trigeminal nerve and develop facial pain. The ability of the surgical procedures to help people who have had, in particular, a post-shingles outbreak of facial pain, or perhaps a Lyme's associated facial pain syndrome, unfortunately, is not as effective as those folks who have what we call classic trigeminal neuralgia. And the term we use in the medical jargon is idiopathic, meaning we don't know why those folks have facial pain. They don't have an infection, there's no mass. What we might see is a normal blood vessel against a normal nerve. And those folks are the ones that respond best to our treatments. So I think there is a lot of investigation going on as to how we can better help folks who have a process that's related to an infection like Lyme's. But unfortunately, the surgical methods that we have are not ideally suited to treat that type of pain syndrome.
Very true. The next question is, can Botox be used to treat trigeminal neuralgia? So I think that that's referring to the various injection possibilities for trigeminal neuralgia. And while we specifically emphasize the three options that we covered earlier, there are alternatives that people try before they come to us. And there are various injections at different parts of the nerve in the face that are tried, and usually they're administered by pain doctors and some neurologists. And so the different medications or agents that are used for those injections can be variable. Dr. Bettegowda, do you have anything else about that?
No, I think that was a beautiful response, Dr. Huang. Absolutely.
Okay.
The next question is about a genetic component to trigeminal neuralgia. So I think that this is, again, one of those areas that's still being studied to understand what are the biological factors, what are the things within our own body that we might inherit from mom or might inherit from dad that can make us more predisposed to having facial pain and trigeminal neuralgia. So as of now, we haven't identified sort of biological factors, things within our own cells, within our own DNA that make it more likely for us to develop facial pain. And so when we counsel individuals who have facial pain, we do not suspect that their loved ones, their children, siblings, parents would be at increased risk for developing trigeminal neuralgia. As far as we currently understand it, it is a one-off process which can impact one individual but spare many, many others within the family.
And the next question is, what constitutes a successful surgery from the surgeon's perspective? That is a great question. I think that Dr. Bettegowda and I would agree that we think success with respect to a surgery is any surgery where the patient believes that it's a success. So that's the most important. We want to make sure our patients are helped with their pain. So if someone has gone through a surgery and they feel like their pain has been reduced and it's helped them, that's a success if they think so. It is different for different people. I would say some people would consider not having an incision behind their ear and having relief of pain if they have a needle through the cheek, that would be success for them because they were able to avoid an open surgery. While others would say that success is defined another way. So we really, that's why there's so much decision making that happens before we offer any specific surgical treatment, because we want to understand what would constitute success for the person that we're treating.
Very well said, Dr. Huang. I completely agree with you. It really is a personalized response that we're looking for with a decrease in pain. And accompanying that would be ideally a decreased use of medications and improved quality of life. But you're absolutely right, Dr. Huang. A very personal perspective is what we're always aiming for within our group. There was a follow-up question to our discussion about shingles, about whether an individual could get shingles but not have the classic rash. So the shingles virus is very similar to the chickenpox virus, and sort of the rash that people get is often in a very specified area. It's often in individuals who are older or perhaps under stress of some sort, or potentially even immunocompromised. And I am by no means an infectious disease specialist nor a shingles expert. And so my explanation is probably going to be very rudimentary. But in general, my understanding is that shingles does indeed typically manifest or present with the stereotypical rash, so that the rash really is a part and parcel of the diagnosis of shingles. Is it possible that shingles can occur without that rash, and that nerve area is still irritated by the virus? I would have to defer that to sort of the primary care doctors and the neurologists who sort of, and the infectious disease specialists to sort of give you a more precise answer to that. But in general, I think the vast majority of our patients who have been diagnosed with shingles do have that classic rash.
The next question is, when can I start exercising again after surgery? So we love that. We love people thinking about recovery because that's really key to getting over any surgical procedure. So if the surgery that we're talking about is the MVD, the ability to ease back into one's usual routine happens, within a few days, I would say. And people usually are in the hospital only 1 to 2 nights after the MVD. And once they go home, they're on a little bit of pain medication to help with the incision. People start feeling pretty well within, I would say, a week or two. Most people do probably take a month off of work, but that depends on what kind of work you do. With respect to exercising, it's whenever you're off pain medications and you start feeling like you can do it, then it's time. We actually leave lots of stitches inside, so it's not like you can pull something out and hurt yourself. Now, if the surgery that we're talking about is the rhizotomy, that is, since it's a little pinpoint puncture on the cheek, one can start exercising actually as soon as the next day, as soon as you feel up to doing it. There's really very little downtime with that procedure. And then, as Dr. Bettegowda said, the stereotactic radiation doesn't even involve anesthesia. It's really minimally invasive, and so there's no limitation on that at all.
Wonderful. I fully agree with you, Dr. Huang. And I think the next 2 questions are sort of intertwined, Dr. Huang. So if you don't mind, maybe I'll answer them in sequence, because I think they're very well linked together.
Yes.
So the question is initially, what is involved with the consult with you as surgeons? And the follow-up is do you recommend that people should get opinions from multiple specialists and physicians? And so to start with the initial question, indeed, I think the process, and I saw on the poll that approximately 60% of participants when that poll was taken had not yet seen a surgeon or in the process of trying to meet a surgeon. So of course, we would be honored and delighted to try to help with any of your particular scenarios. And what would be initially involved is a intake where we actually send out a questionnaire to be able to understand specifically with relationship to the trigeminal neuralgia, what is the type of pain? What's the quality of the pain, the location, the triggers? What have been the opportunities or medications done, surgical interventions done, and a brief medical history to try to understand what is the type of pain that you are individually experiencing. And if that initial questionnaire seems that we as surgeons are the best suited to be able to help you, then of course we would arrange for a visit to meet with us either by telemedicine or face-to-face, depending on your preference. In that scenario, we do often like to see an MRI scan ahead of time to be able to understand, is there a compressive force on the trigeminal nerve? Is there an abnormality that we see that needs to be addressed in order to help the facial pain? So we do encourage folks to have an MRI of the brain prior to seeing us, as it can help guide our discussions very much. The visits can be scheduled at your convenience. We try our best to be very prompt and to be able to see a large number of folks. If it appears that we're not the best suited specialty, we know that surgery is not the right answer for everyone. We do try our best to get you in the hands of pain management teams if that's appropriate, neurologists if that's appropriate, or a clinical trial as discussed earlier. And so again, it gets back to what Dr. Huang said at the very beginning, which is to try to provide a personalized treatment plan that suits the type of facial pain that one is experiencing. Related to this is, should an individual seek multiple opinions? And I always encourage folks, particularly ones who have questions about a medical condition, whether it's trigeminal neuralgia or otherwise, to seek opinions from a variety of experts. We know that many of our patients have already seen dentists, have seen neurologists, primary care doctors, oral surgeons. A number of different providers have often weighed in and have tried to help people in their journey. And this, I think, is very useful because it allows us to understand what is helping, what is not. Is this truly trigeminal neuralgia? Is it another type of facial pain? And so even when it comes to seeing a surgeon, we'd be delighted to see you if we're your first surgeon that you're seeing, or if it's a second opinion or a third opinion, because our goal really is to help you feel comfortable with that treatment option. And so I do encourage folks who do have additional questions to continue to seek out providers to gain the appropriate answers for those.
I couldn't agree more. The next question is, do you have any advice for someone caring for a loved one with trigeminal neuralgia? And I think that's a great question because it shows that this type of pain really affects not only the person suffering from the pain, but those around them. And I would start by saying that trigeminal neuralgia pain is really one of the worst types of pain that anybody can live through. It is very unlike any other human experience, and it is excruciating and really, stops people in their tracks. And as someone who is, close to a patient with trigeminal neuralgia, I think understanding how much discomfort one is with that type of pain is very helpful in allowing one to be supportive and really helping someone through these episodes of severe attacks. It's, being present and trying to help them as they get through, making sure the medications are being taken on time, and really also offering a support and, starting to keep track of how successful the treatments have been. I'll just recall that many patients do have trigeminal neuralgia for many years that are managed with medication. And then gradually the medication stops working. And I think that if you are taking care of someone who has trigeminal neuralgia and you're the first one to notice that, the medication stops working and is not helping and the side effects are adding up, that, you sort of your knowledge about other options and helping them to find us either for a second opinion or a third opinion or an initial opinion. I think that those are things that you can do to help your loved one who is suffering from trigeminal neuralgia.
I agree, Dr. Huang. That was just such a very thoughtful question from our audience, and I can't believe that we're coming up on the hour and have about 5 minutes left.
Wow.
It's been very it's been a great discussion here. I think there are a couple of more questions that I think we can get to. The next is, who would be the best candidate for microvascular decompression? And this is getting back to what Dr. Huang said, where we really like to have a high resolution MRI scan of the trigeminal nerve to best identify if there is vascular compression on that nerve. And so we certainly offer a very high resolution scan, a specific protocol that our neuroradiologist here at Johns Hopkins developed. And that scan, if it would be of benefit to patients, we're happy to order for you after you've been evaluated by us. And that helps us understand what is the anatomy of that trigeminal nerve. If indeed there is vascular compression, then we think that that individual, if they're able to tolerate the anesthetic risk, which is small, because this procedure lasts about 2 to 3 hours for most individuals. So it is a relatively brief procedure, but if one is healthy enough to handle that amount of anesthesia and stress on the body, and there is a sign of vascular compression, then we really do think that that individual would be a very good candidate. We often get asked, is there an age limit cutoff whereby after which we say, no, you're not eligible to microvascular decompression? And I think I can speak for Dr. Huang that our answer to this question is absolutely not. We really treat the individual and not the number. So we certainly perform microvascular decompressions in individuals older than 60, older than 70, and on occasion even older than that, depending on the overall health and clinical status. And so we think that those are important considerations to keep in mind.
Great. Wow, we are really winding down in terms of time. Amazing. There is one question of how long do the benefits of stereotactic radiation last approximately? Usually it's durable because radiation effects are not entirely reversible. So I would say that usually it's several years. However, there is a chance that because stereotactic radiation is using high dose energy to damage a portion of the nerve, not the entire nerve, just a portion of it, that there are some people whose nerve actually recovers from that high dose energy and that insult. And in those situations, people start noticing a return, but that's very infrequent. Okay.
So I think we have time, Dr. Huang, for one last question. I want to thank everyone for their participation tonight. And this question is, do you recommend watchful waiting for some patients? It's a great question. I think it strikes to sort of the natural history of trigeminal neuralgia and facial pain. So in many individuals, trigeminal neuralgia starts very slowly, very infrequent episodes, may not even need to be treated with medications, and the pain goes away for days, weeks, months. And I've seen patients where pain episodes are years apart. And certainly in those scenarios, we would not recommend any treatment with any of the surgeries discussed today. And watchful waiting indeed is the best approach. The patients that should consider surgical interventions are those where the pain is severe enough to impact quality of life and where medications are not an option because of side effects or insufficient to control the pain. So by watchful waiting, if someone hasn't tried medications, we would suggest that indeed, please try that first. Or if the pain is so infrequent that it's not impacting your quality of life, then certainly not proceeding with the surgical procedure makes a lot of sense.
Absolutely agree.
So very much thank everyone for the time. Morag, Amy, do we have additional information for our participants tonight?
I think that's a wrap.
Yeah, no, I don't think so. Thanks everyone for joining.
Okay, great.
Thank you so much, everyone. Stay well.
Thanks, everyone. Thanks, everyone. Bye-bye.
Bye-bye.